Okay, hello. You're Dr. Raja and I'm Mr. Sanderson, and the purpose of this station is to test your knowledge and experience of urodynamic studies. Okay, so the first thing I want you to do, I've got a trace here which I'm going to need you to look at in a minute, but first of all what I'd like you to do is to just describe the procedure of cystometrogram for me. So beginning with the patient coming into the room and you're there with someone carrying out the study, and I'd like you to tell me the procedure as it follows from there.
Yeah. First I would introduce myself to the patient and then say that we would expect you to come with a full bladder, as full as possible, and then the first thing we would ask you to do is empty your bladder into a special container which we could measure the volume as well as the flow rate, and then we'd lie you down on the bed. And I know it can be embarrassing, but you will have privacy even though we would be in the same room.
Good.
And we lie you down on the bed, and then we put a tube in your bladder.
So you put the tube into the bladder, as you say,
We put the tube into the bladder. And
as you say, to measure the residual urine that's in there.
Yeah.
Okay.
Okay. And this tube also measures the pressure in your bladder. We also put another tube in your vagina to measure the pressure. Okay. And then we connect all these tubes to a machine, and we'll fill you up with water. Okay. We will then ask you to tell us when you can feel the first urge to wee. Okay, so that we can note it down. And then we'll sort of still continue to fill your bladder up till sort of till you can really bear it.
Right.
And then we'll ask you to sort of do a lot of things like cough, jump around and things like that. This is really to make you leak, because the main reason of this test is to find out why you're leaking.
Okay.
Okay. And then then I ask you to empty your bladder again, but this time with the tubes in place. Okay, so that we can again measure the pressures as well.
Okay.
Then the computer will sort of give us the results in graphs, so that we can then talk to you about the results.
Excellent, that's perfect, thank you. Good, so that's a good start. That's just what I want to hear from the conduct of the test. So you obviously have seen this done before. What I have here is an example of the tracing from a urodynamic test, particularly a cystometrogram. What I'd like you to do is to relax, take a moment, have a look at this trace, and then I'd like you to describe it to me. Okay? Okay.
Okay. So we have a patient here and everything, so it is a cystometrogram done on the 19th. Okay. And it has 5 lines. And the first of which is the volume infused. Okay, which is measured in terms of mils per minute, and it's from 0
volume
to
in mils per minute? The volume infused in mils, you mean, not mils per minute?
Mils.
Okay.
Yeah, and it's ranging from 0 to 1,000.
Yes.
Okay, and this is the voiding graph, and it is measured in mils per second.
The flow rate,
the flow rate, and it's ranging from 0 to 50. And
so could I just ask you which line you were talking about there relates to the urine flow rate? The browny red one. Okay, there's another line there as well, isn't there?
Yeah.
Okay, what do you think that represents?
That is the voiding volume.
Yes.
The volume voided.
Correct. Okay, carry on.
Okay. And this line is the digestive pressure, which is measured in centimeters of water, and it ranges from 0 to 100. Okay. And this is the abdominal pressure, again measured in centimeters of water, ranging from 0 to 100.
Right. And where is that measured?
It is measured with a catheter placed in the vagina. Okay.
And what if the patient's got a major prolapse?
We can measure it from the rectum as well.
Okay, that's fine, thanks. So you told me about this one, and then finally...
Sorry.
No, it's okay.
This is the recycled pressure, which you measure from the catheter in the bladder. And this is the abdominal pressure, which we measure from the catheter in the vagina. And this is a sort of the computer then detects this
which one?
The recycled pressure from the abdominal pressure.
Are you sure?
No, the recycled pressure is not. So the abdominal pressure from the recycled pressure
right.
to derive at the detrusor pressure.
Absolutely correct. That's good.
Yeah.
Okay. So those are the lines.
Yeah. And there are 4 phases. First is the voiding graph. Yeah. No, this is a systemetry.
Yes, it's as you say, the first part of the free flow studies here.
Yeah.
I can see from this trace it's quite easy to miss that, but it's this section here, as you say.
Okay.
And what are the other 3 phases you were going to tell me?
The filling phase.
And where is that on this graph?
From this line. And this is the first.
Yeah, this is the filling here.
Till here.
That's right. Yeah.
Okay. And then this is the.
What do we actually do during that phase?
We ask them to cough and sneeze.
So we're provoking the bladder.
Provocation
That's
phase.
right.
Okay. And this is the pressure study.
The pressure flow studies, yeah. Correct. Okay. So could you show me, tell me about this particular trace and what it might show?
Okay. The free flow is, I think, 10. It's normal because it's 10 and it is a curve.
So tell me the scale of this graph. So you told me before it goes from 0 to 50, so what does each small divider represent?
10.
That's right. And where is the peak flow? There.
15.
Okay. 15?
15 mils per second.
Okay, so it's 15 mils per second this. But is there something else that's important to know about that void?
How much she voided. What is the volume
and how much
of
do you
the
think
void?
she voided?
Almost nothing.
Almost
really.
nothing.
Yeah.
Okay. So is this meaningful?
No, not really.
Okay, that's good. So then
I would also like to know the residual.
Okay, yeah. So there was no residual.
Okay. And then they put in about 333 mils.
Do you know at what rate that's filled?
It's usually 50 mils per.
Correct.
Okay. And she had a first urge at 160 mils, which is okay because it's half the total amount of volume in both. And there's no detrusor activity. There's no irritability in the detrusor.
No individual contractions, that's true. Okay. So what else do you like to look at? You're looking at the detrusor pressure line here, which is important. Yeah. And what else do you like to see in that while the bladder's filling? You were looking for contractions, that's right. Yeah. Anything else that's important in that pressure while you're filling the bladder?
The pressure rise. And it has risen to 25.
Yeah.
31.
Yes, well, yeah, there's a figure there to actually help you, but as you say, yes, it's certainly above 25.
25. So the
25 what?
Centimeters. So it is a bit high.
A bit high, okay. What would be normal?
15 to 400 to 500 mils.
Okay, so there's 31 at 333 mils. Okay, fine. If you'd like, can you just talk me through the rest of the trace and then we'll go back to talking about that?
Yeah. The provocation test.
Could you tell me what these lines are here? What these lines represent on the detrusor pressure? What do you think might be happening at those points?
It's from interference line.
While the patient's doing what?
Coughing or sneezing or
that's right. So
jumping
this
around.
is interference, as you say.
Yeah.
And what's happened with the bladder pressure during that phase of the test?
It has increased slightly.
Oh, slightly, but
34
it
minutes.
sort of
So,
more or less stayed as a straight line, as you
Yeah.
say. Okay. And there aren't any annotations here, are there, of
does
leaks
it-
or whatever.
Yeah.
So as far as we can see here, she didn't leak any urine during the course of this test.
Yeah.
Okay. And the final phase of the test,
It's 25.
what is
Avoiding
the
flow rate.
yeah,
is
the urine
25
flow rate is 25
ml per second.
mils per second, that's right.
Yeah, and
Is that okay?
yes,
Okay, so what would be normal for a lady?
anything about 20.
Anything above, well, that certainly would be the case, or
Yeah.
anything above 15 we'd probably
15,
accept for a lady, that's right.
Yeah. And the volume is 312.
That's right. So
we put in 333.
and she voided all of that,
Yeah,
really.
Yeah.
So would you say that her urine
Looks
voiding...
normal.
It looks normal?
Mm.
Okay, that's good. So could you just give me a few word summary of the key features of this test?
It's a urogram showing
Uh-huh.
a normal flow
Normal voiding
pattern,
pattern,
normal
yes.
voiding pattern, no demonstrable stress incontinence, and suggestive of detrusor instability.
Okay, we'll get to what the possible causes might be in a minute, but as you say, this has shown an abnormal rise in pressure during filling. Okay,
Yeah.
so you were going on to tell me what might be the cause of that, and one cause you think might be detrusor,
Instability.
or nowadays we call
irritability.
that detrusor overactivity.
Yeah.
Okay, and do you know what the other possible explanations for this might be?
That we haven't zeroed the...
Well, there could be technical issues, but I think we can
Absolutely.
assume that this isn't to do with that. Any other possible explanations of the bladder where we have an abnormal pressure rise? And is that a capacity of 333? Would you say
Yes.
that was...
It's a bit less.
It's at the lower end of what would be normal, and she's got a high pressure for quite a low capacity there. So that could either be because the bladder's contracting, as you say,
Yeah.
or what other explanations might there be? Causes for the bladder not being able to stretch anymore.
Fibrous bladder.
Exactly. So what sort of things might cause a fibrosed or stiff bladder?
Any previous radiotherapy?
Radiotherapy, that's certainly a possibility. Or any inflammatory causes that you know of? Infections, acute infections, certainly. Cystitis, this is exactly the picture you would see from acute cystitis. Yeah. Or any other types of anything else? Interstitial cystitis, exactly right. Don't sound uncertain. These are all possibilities. Yeah, very good. Okay, so if we assume that, so if you are the doctor who's carrying out this test and you got to the end of it, how would you think you would manage this lady?
I'll have to discuss with her about lifestyle changes, like fluid management, cutting down on caffeine. If there is any suspicion of infection, which we would have found out from the MSC results, so we could treat that as well.
Certainly.
And I would advise her to see a continence nurse to arrange for a outpatient urine drill.
Very good, yes.
I would also like to prescribe her some tablets, anticholinergics.
In the absence of infection. Okay. And then what would be your plans after that? So you'll give her some anticholinergics and ask the continence advisor to help manage that for her.
Yeah.
And then any further instructions, or would you be reviewing the patient, or?
Unless the continence nurse wants us to.
Okay. Yes, it will depend on your local arrangements, but if you have a local arrangement where the continence advisor may then let you know if there hasn't been any improvement. And if her symptoms haven't improved within a couple of months of instituting this treatment, what do you think might be the next line of management? Because we'd hope if it was diffuser overactivity, which you're treating for, she would improve.
Yeah.
Which means we need to look into the other possible causes.
Yeah.
So what do you think we should do?
Bring in there for a cystoscopy.
Yeah, good idea, do a flexible cystoscopy. Okay, that's excellent. Thank you very much.
Thank you.
Well done.
Hello, Mr. Shukri. How can I help you today?
Well, Ray, I don't know what to tell you now. I mean, can you understand what it means to have 5 children and then go finally think that this is the solution to your life? You go for sterilization, and then after that, what's happening now? My wife's pregnant again. Can you understand what I'm going through here? And what this has on my life, and I mean, I don't know what to say anymore. My life is a mess now. I don't know. I'm having to loan money. Financially, it's a disaster. I mean, I can't believe this. And who's responsible for this? Is it you responsible for this? You're the one that did this, aren't you?
Well, I mean, first of all, let me say I'm sorry to hear what's happened to your wife. I know that she wanted, to be sterilised and have no further children, and this is a potential complication that was explained to her at the time, that sterilisation can fail in 1 in 200 to 300 cases, and I'm sorry this has happened. In terms of responsibility, the consultant in charge of the case takes ultimate responsibility. Yes, I was the registrar who was present at her operation.
Why didn't the consultant do it then?
Performed it.
I mean,
the consultant was there in the theatre supervising my operation.
well, obviously you're not qualified enough to do this, because if he should have been doing it, then why do I have? I mean, don't they know that I've got 5 children? A person with 5 children, shouldn't the consultant be a bit more courteous and do it and do it himself, knowing that my situation? And what now? What am I going to do now? Who's going to take care of this child? Is your consultant going to come and take care of the child for me?
Well, I am capable of doing laparoscopic sterilizations. I've done over 100 laparoscopic sterilizations with supervision, and therefore I have been deemed as competent in doing sterilizations, and my consultant was in the theatre.
Well, obviously not in this
What
case.
normally happens. But even a consultant doing a sterilisation, the sterilisation can fail even when the operation has been done absolutely correctly. The clips can fall off, the tube can grow around the clip, and it can fail. Whichever method of sterilisation you use, even vasectomy, can fail.
But I don't remember anyone telling me any of this.
This was explained to your wife, and it would be nice to meet up with your wife.
Well, she's pregnant right now, unfortunately, and tired. I mean, she's at home feeling sick at the moment, and I don't blame her. Pregnancy and this, what it's caused her, she's in a total mess at the moment.
Yeah, I mean, I appreciate that, but obviously, from a confidentiality point of view and everything as well, she is really my patient, and consequently, I know she's given permission for me to talk to you, for you to talk to me today. But obviously, we would like to check that she's all right. Together, she's very sick and has got hyperemesis of pregnancy at the moment, and obviously, we'd like to check that she's all right and look after her.
Well, looking after her is fine, but I'm not worried about her now. I'm worried about this baby that's coming. Who's going to? I mean, I think I probably need to just maybe sue the hospital. That's probably what's going to get me my money back. Because who's going to pay for this child now? Am I going to take it out of my salary? I don't have enough money for this child. Basically, I've got already 5 children.
Well, that's something that I can't fully answer, I'm afraid, at the moment. The proper course of events is, clearly I would like to meet up with your wife and you. To go through the notes and the case and the consent, and to go through what's happened in detail with you and explain it with you. Now, when an event like this does happen, we have something called risk management, and we would look into a case like this in some detail to see whether there was anything that we could have done differently. And that is something that we'll need to do in the future. If you wish to make a complaint and you're not happy with things, then the correct course of procedure would be to write a letter to our legal complaints department via the chief executive of the hospital. If you address the letter to the chief executive, then it would usually go to the complaints department, and then we would form an internal investigation, and if necessary, involve an outside ombudsman or external assessor, if necessary, to look into the complaint.
But then, what if this, I mean, this complaint, am I supposed to get some money out of it now for this baby, or what's going to happen? Because that's my main issue. I don't care right now that the complaint goes through, and that's fine, and you're going to improve your system, but what's that gonna help me? Is it going to improve what's happened to my wife now? Or, so I need to know, I mean, you tell me, what do you think my baby is worth at the moment, that you've just, because of your mess up that I'm having to deal with?
Well, I can't put a price on a baby. I don't think anybody can put a price on a baby, with due respect. So that is not for me to say.
Well, how much does it cost to raise a baby, let's put it that way?
Well, I know it's a very difficult question to answer, and I certainly don't feel that it's my place to answer that. I think the right course of events is, as I've explained to you, is to have a meeting with your wife, so that we can go through things in detail, and we will then discuss, first of all, looking after her and her health. That's the paramount important thing. If you feel that you wish to sue the hospital or sue me, that is up to you, but the first step would be to go through the complaints procedure.
But why is it that this has happened? Can you just explain to me why does it fail? Why is this failure? Is it the clips weren't put properly? Or what happened exactly? I just want to understand.
It is possible that clips aren't put on correctly. However, looking at the operation notes, when we do a sterilisation, we routinely take a picture of the tube and the clip over the tube. And looking at the operation notes as I have, we have a picture of both the right and left fallopian tube with the clip completely occluding both tubes and in position correctly. Therefore, we have done everything within our power to perform the sterilisation correctly. And even when the operation goes absolutely correctly by the book, there is still a failure rate of 1 in 200 to 300, and I'm afraid that is what has happened to your wife in this situation. It is important that we assess that she is all right, to assess the pregnancy is in the right place in the uterus, because ectopic pregnancy is a potential risk on somebody who has fallen pregnant after a sterilisation as well.
Well, I don't know. I mean, I just think this is a kind of a cover-up thing. I'm not satisfied with this explanation. I'm sure you've done something wrong. I'm going to sue you, and I'm going to actually go to the papers, because something has totally gone wrong with me, and I'm not